we're looking forward to it and we'll enjoy it.
Thank you.
Welcome, Brian.
Is that coming? Is the mic on? I can't really tell. Good enough? Mm-hmm. All right. So, as Dr. D said, my name is Brian Dupree. I'm from just up the road. If you're going towards Texarkana, a little bitty town called Ida, that's where I grew up. It's about 250 people there. I went off to Knoxville, Tennessee to do radiology training, then went to Emory to do a neuro fellowship, and I came back home. This is where I wanted to raise my family, and you know, I really enjoy teaching, so I'll provide my email at the end. I've got tons and tons and tons of neuro cases. If anybody wants to do board reviews or anything, just email me. I love to teach, and I love to interact with residents. I'm not sure how many of y'all will be rotating over at the VA, but feel free to stop by anytime. So my talk that I wanted to cover is a topic that is, when you get this case at the view box, most radiologists, in my experience, either dread it or avoid it or pretend it's not there. So I just kind of wanted to go over some basics of brachial plexus anatomy, because once you understand the anatomy, most of us have looked at enough MRIs to know if something's bright on T2 or STIR, it's probably concerning. And then I hope to give you a couple of tools you can use to kind of be less make these cases less dreadful. So I hope we can accomplish that. So the goal of this talk is to review the anatomy, look at the MR protocols to kind of decide what planes we can use and what sequences we can use to best determine if there's pathology. Because a lot of these scans, they'll do them kind of as a just in case, at least in my experience, and a lot of them turn out to be negative, but when the positive case comes along, hopefully we can go through some protocols. So if you're asked by a tech to, hey, what sequences or planes do we need to do, you'll have a good idea. And then we'll look at a few practice cases that I saw in fellowship just to kind of show you some pathology. And hopefully at the end you'll feel more comfortable with these cases. So here's the general outline. We'll start off with some anatomy. We'll go to kind of how I like to break down the brachial plexus. I break it into thirds, and then we'll again look at how we can image it, and then the cases at the end. So anytime I get a topic that is daunting or complex, I like to break it down into components and make it as simple as I can. That's just the way I learn, and then you can build on that. So we'll start out with just reviewing, since we're talking about the brachial plexus, we'll talk about the peripheral nervous system and what that's composed of. And the main thing we want to talk about today is spinal nerves, but it also includes other things like cranial nerves and how they communicate via neurons between the CNS and the rest of the body. But the part we won't talk about is the autonomic nervous system parts, sympathetic trunks, and the enteric nervous system, which also is a part of the PNS, but we'll mostly focus on spinal nerves today since we're talking about the brachial plexus. So kind of zooming in from that bird's eye view, we'll start talking about the spinal nerves. There's 31 pairs, which allow the CNS to transmit information back and forth between the extremities and the CNS. Remember, there's 8 cervical, and then 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal spinal nerve pairs. They start out at the spinal cord. The spinal cord gives off dorsal and ventral roots, and then those merge to form a spinal nerve, which then again branch to become dorsal and ventral rami. Now, the dorsal rami mostly just innervate the paraspinal musculature in the skin. We're not really going to talk about those today, because what we really want to talk about are the ventral rami, which give off innervation to the limbs, and that's really what the brachial plexus does for our upper extremities. So I know this is lumbar spine, but I think it shows well what kind of the anatomy that we just went over in text form. I like, as radiologists, we like to see images. So you have a coronal image here on the left, spinal cord giving off the dorsal and ventral roots, dorsal root ganglion, becomes the spinal nerve, and then branches again. You can see how much more robust the ventral ramus is compared to the dorsal. And then if you go over to the axial image, you see the dorsal ramus comes off and does the paraspinal musculature and skin like we mentioned. And then if you can move this up into the neck, you could see that the ventral ramus comes off and would go down the arm. So that's kind of, again, just starting with the basics. The ventral rami in red is kind of what we're talking about today. So taking it one step further, brachial plexus, again, the ventral rami, typically it's anywhere from C4 to T2, depending on if it's prefixed or postfixed, but the standard is C5 to T1. So you get the lower four cervical nerves generally give off the ventral rami to form the brachial plexus, and then the first ventral ramus of T1, or the T1 ventral ramus. So if you hear or read about prefix, that just means it'll go from C4 down to C8, and then if it's postfix, it would be C6 to T2. So, and your neurologist would have to help you with that. If there was an injury and they noticed there was some T2 injury with it, then that's probably a postfixed brachial plexus. But you would need some help from your clinician on that one. So here's where we kind of start to break it down into thirds. We all saw this diagram in med school. I know I probably drew it 50 to 100 times over and over and over until I was able to pass the test for gross anatomy lab. But as far as the brachial plexus, again, C5 to T1, and then if it's prefixed, you have some, you get some from C4, the contribution there. If it's postfixed, you get some T2 contribution. I like to break it down into thirds. So there's a supraclavicular part, which comprises the rami and the trunks. The middle part just includes the divisions, and then the infraclavicular part includes the cords and the terminal branches. So if you can, most of this is kind of based off a sagittal image. If you take a sagittal image and scroll back and forth, if you can find the clavicle, the scalene muscles, the subclavian artery and vein, and then the pectoralis musculature, you should be able to break it down after we get through with these slides. And based on where you are, your supraclavicular, you know you're dealing with roots and trunks. If you're behind the clavicle or retroclavicular, you're dealing with divisions, and then infraclavicular. And so you want to do the best you can whenever you get pathology to kind of narrow it down for your neurologist or neurosurgeon so that they can kind of make sense of what's going on. A couple of key things to remember in the brachial plexus, C5 and C4 contribute to the phrenic nerve. And also, so if you have diaphragmatic paralysis in a patient, you might be able to localize the lesion based on that history. And then if they come in with a winged scapula, you've got some, likely have some involvement of the long thoracic nerve, which innervates the serratus anterior. So going from this image to this image, I like this image because you can see how much further the brachial plexus spans out than it just seems a lot more stretched out. This is more like real life. So you have that supraclavicular part, the retroclavicular part, and then the infraclavicular part, and you can kind of see how these parts of the brachial plexus orient to structures like the clavicle, the scalene muscles, and the arteries and veins. So I like this image better than the other one, and kind of bringing those concepts into this image, and we'll keep going with that. Another Gray's or Netter's picture here showing the relationship of some of these muscles, like the anterior scalene, which will be really important as a landmark, and how the phrenic nerve lies on top of that. And just, again, the relationships between all these brachial plexus structures, there's just a lot of important structures in this region. So, again, just trying to drive this point home. If you're supraclavicular, you got roots and trunks, retroclavicular divisions, and then below the clavicle, you'll have the cords and branches. Now this is the way I like to break it down based off a sagittal image. I start medial and I work my way out. I start at the source, the spinal cord, and just slowly work my way out, and I find these structures every time I read a brachial plexus study. So I start at the cord, and that image isn't here, but then as I come lateral, you find the anterior scalene, middle scalene muscle, the first rib, and the subclavian artery. Once you find those parts, you know for a fact, if it's a sagittal image that's true to midline, that you'll be in the supraclavicular region. And you'll know that the roots and trunks lie vertically in between the anterior middle scalene muscles and also the subclavian artery in the first rib. So if you have a lesion, let's say it's a metastasis, and you see the fat between, all the white here is fat, and then these circles are the nerves. If you see some blurring of that fat or abnormal signal or mass effect, you could tell the clinician it's supraclavicular, probably getting C5 and C6, and see if that matches up. And that's really all you're trying to do, is find the abnormality and do the best you can to help them localize. So this triangle here is called the interscalene triangle. Yeah, interscalene triangle is kind of what this image represents with all these structures we just went over. Then I come further lateral, retroclavicular. It's not right behind the clavicle, but that's the way it's named anatomically, so we'll go with it. You find the first rib, you're more lateral, so you're gonna see more of it in the field of view. You're gonna have your subclavian artery and vein. And the structures now are divisions, and they're gonna lie over the top and behind the subclavian artery. So once you find this first rib, more horizontal lie between the two vessels and the clavicle all in the same plane, you know where your nerves are, look for an abnormality there, and then just work your way lateral to see if it involves anything else. So coming more lateral, you get to the infraclavicular region, and these are going to be your cords and branches. This is a little bit more medial, so these are the middle, posterior, and lateral cords. And now you're at a point, you're past the first rib, so this is the axillary artery and axillary vein, pectoralis musculature. Once you get to the pecs and out past the first rib, you know you're infraclavicular, and you know where these structures are. So this is called the retropectoral space, costoclavicular space, and interscalene triangle. And again, if you just find those images and kind of follow it out, you'll be able to localize the lesion a lot better. We already kind of talked about this: roots, trunks, divisions in the middle, and then your cords and branches. There's another way you can do it. It's just confusing, but I'll go over it just because in case you like it a little bit better. Another landmark you can use is kind of goes along with the first one. Use the clefts between the anterior and middle scalene muscles. You'll find your roots and trunks. And then if you go to the lateral border of the first rib, you're starting to blend the trunks and divisions together. And then medial to the coracoid process, you can find your cord. So just a second way you can divide it out. I like the first one better. So if this video will play, I got this from eAnatomy, and this just kind of shows a T2 image, and you can, if you have high enough resolution images, you can follow the nerves from the cord all the way into laterally through the neck and down into the axilla. And that's a good way to start if you're learning how to read these, is just start at the cord and work your way lateral and do your best to follow the structures. Then find those landmarks we talked about, and you should be able to follow them pretty easily. And we'll quickly go through these axials. Same concept. Usually with brachial plexus imaging, you're going to have 3 planes. This is just following the nerves with an axial image, also T2 weighted. And then a coronal finally. So until I got comfortable with the anatomy, I didn't feel comfortable reading these cases, so If you can find in your archive a normal brachial plexus study, just look at it a couple of times, find those nerves, and every time you come to one of these cases, probably the first 10 or 15 you'll have to review the anatomy, but after that it'll come to be second nature to you. So now we'll kind of go through imaging examples and protocols of how to image the brachial plexus. So the bare bones clinical exam is helpful. Hopefully if you get one of these studies you get a better history than just trauma or something like that. But if you don't, you might have to pick up the phone if you're kind of at a loss on your images. EMG testing can help you. And then the things we're going to focus on today is myelogram and a brachial plexus MR. In Europe, they do some ultrasound brachial plexus stuff. I haven't been exposed to that, so I left that out of the talk. So clinical information, you can have any number of symptoms from pain. Then some of the other things we talked about, if the injury's in the right place, you can get scapular winging, diaphragmatic paralysis if the phrenic nerve's involved, and also Horner syndrome because of the postganglionic fibers from C8 and T1, which can be involved. But depending on the type of pathology, you may get different symptoms, and that can potentially tip you off. For instance, if you have a baby that falls off a bed and kind of stretches their neck, they'll have a motor deficit as a common presentation. With neoplasm, you get pain down the arm. And then if the patient's a breast cancer patient who's had radiation or a lung cancer, you could potentially get some sensory deficits there. So I pulled this chart from Gray's Anatomy. This is just one that I kind of keep close at hand. If I'm pulling up a brachial plexus study, I'll just pull this chart out and see if when I call the clinician, ask about some of these, if the patient can do some of these things. For instance, like can they abduct the shoulder, can they flex and extend the elbow, and it may help you localize kind of where to look. And it always helps whenever you're imaging these patients if you know what side the deficit is. I mean, I can't tell you how many cases I've seen where they just put, brachial plexus imaging trauma, and you don't even know which side they're worried about. And that's really helpful for MRI because you want a coronal to compare both sides, but the part that you really want to know about, the good high quality images, you'll want to know which side. Then you don't waste your time imaging both sides, and you can get the patient off the magnet faster and you'll get a better study. So myelography, we still use it today. If a patient has a pacemaker or they're too claustrophobic to lay in a magnet, this is still a great study. The advantages are you still get really great evaluation of root avulsion injuries, which I have an example to show y'all. Really great resolution of the nerve roots as they're coursing through the contrast stained CSF. And then some of the disadvantages, you have to put a needle in somebody, so that's a disadvantage. It can be tough doing it on babies. And then, anytime you have a CT of the chest, you've seen that beam hardening artifact as the shoulders come into play. And the other bad thing is they're such small structures, you really can't appreciate nerve edema quite as well as you can on MR, just comparing the two. Now, MR, on the other hand, is really the go-to imaging modality, in my opinion. You can see edema, you got great soft tissue contrast. It's non-invasive. It's really sensitive. You can help differentiate pre- and post-ganglionic injury, so you can tell your surgeon that can put them in different categories as far as, is it going to be physical therapy as the treatment and pain medication, or is it going to be a surgical case? And then you can get good depiction of pseudo meningoceles, as you can see them on myelography, but you get a little bit better visualization of them because some pseudomeningoceles will not fill with contrast. The disadvantage, the patient has to lay there longer. A lot of them are in a lot of pain, and you may not get great images. They're motion sensitive. So, and then again, patients who just can't get in there because they have a pacemaker that's not MR compliant. Again, going back to simple, what does normal look like? And then kind of go from there. So when you're looking at your T1 weighted images, try to follow those nerves as best you can through the fat. The fat is going to be bright, and then the brachial plexus nerve fibers are going to be iso-intense to those adjacent scalene muscles. So use the fat as your friend to see those dark cylindrical structures running through the fat. If it's a cachectic patient, you might not be able to see it. You might have to rely more heavily on your T2 weighted images. And those nerve structures, again, compare those to muscles. They're going to be a little bit more hyper intense on the T2 weighted images than your muscles. So you're going to be looking for edema, and your coronal image, you can compare both sides to see, you know, is the affected side brighter, and you're looking for abnormalities. So then we'll get into what do the abnormal MRI findings look like. Fat is your friend. If you have blurring of that fat, could be edema, could be tumor. So if the fat looks clean, that's a good first step to think, all right, there might not be anything going on, but you typically rely more on your T2 images where you're looking at for markedly hyper-intense abnormalities and mass effect. Like with MR imaging in musculoskeletal radiology, you still can get that magic angle around 55 degrees. So you compare both sides to make sure that it's not artifact, that it is a real finding. If the nerves get enlarged, like focally, it could be something like a nerve sheath tumor or a metastasis. And then use your post-contrast T1 weighted images with fat suppression to look for enhancement. Not just looking at the nerves, look at the structures around it. If you have atrophy of one side, one muscle group compared to the other side on your coronal images, that can be a telltale sign of what's going on. Look for fatty replacement of those muscles in the later phases. And then myositis and abscess. Look at your post-con images, not just enhancement of the nerves, but I've seen a case where there was disc osteomyelitis extending into the adjacent musculature and soft tissues. So that's another thing that you might not be looking for, or if you're not looking carefully, you may miss it. So how do I use different planes to evaluate the brachial plexus? Again, sagittally, look at the relationship of the brachial plexus lesion to the subclavian artery and also the axillary artery and those adjacent muscles, those landmarks that we went over earlier. On the coronal, again, you're comparing the affected side from the contralateral side as a kind of control to see, is it really abnormal, or is this magic angle, or is it nothing? So protocol-wise, again, find out which side is affected, because that's where you're going to image with a smaller field of view, and you'll get better quality images. You'll also decrease the scan time for the patient. So they don't have to lay in there quite as long. So the coronal images will get both sides, and then the sagittal and axials will kind of be more tailored to the affected side. Again, 3 planes is really highly recommended. We definitely, when I was in my fellowship, we caught some subtle findings just because we did all 3 planes. And again, talk to your clinicians so you can find out where they think the injury is, so you can really hone in on that area. In the future, as magnets continue to get more fine-tuned and we can have higher magnetic field strengths, there's already studies coming out with MR neurography following the nerve down distally. DTI, DWI, if you can add that to your protocol, that can be helpful. And there's still a lot of room for growth, because frankly, on a lot of magnets, these images still aren't the best, but they're getting better every day. So here was the protocol that we used at Emory. A localizer like you do on everybody. Then we had 1 axial T2 weighted images, set of images, and then we used sagittal and coronals pre and post contrast T1, and then we added some T2s, and the T2 space are kind of like, depending on your magnet space, KISS, those really thin section slices, and you can actually see the nerves really well whenever you get those thin slices, which is helpful when looking for subtle pseudomeningoceles and preganglionic injuries. So we're coming toward the end. We've got, I don't know, 5 to 10 cases here. These videos go pretty fast, so I'm going to kind of scroll back through them. So again, I like to start at the cord and kind of work my way out. This is a kid who fell, and so just kind of following it out, you start to see the nerve roots coming out. Right through there, they're coming out and going down toward the axilla. And whenever I'll show you the coronal images as well. And the right side, the affected side, was a little bit brighter than the opposite side. And upon more clinical history, not only was it a fall, there was this actually turned out to be a sad case of abuse where the parent threw the kid off the bed, and being a small kid, his head is still proportionally large, and ended up having a stretch injury. So kind of subtle. You're just looking for subtle differences in signal on cases like this. This is a stretch injury. Luckily for the kid, he didn't have a pseudomeningocele or a preganglionic injury, so he'll likely has high probability of good recovery. But cases like this, you're just looking for subtle differences in the T2 weighted images. The nerves on that side were just barely enlarged and hyper intense. Luckily, again, no pseudomeningocele or cord injury. So again, preganglionic injury would have been worse. Typically, those patients just go to physical therapy. They don't have a great chance of recovering. Another trauma case. This one goes fast, but you'll start to see the abnormality in the spinal canal. And I've got some still images coming up. So there's a coronal reformat of those. Another great advantage of those space images that I talked about is you can do reformatted images. So you can see in the spinal canal there's asymmetric T2 hyperintense signal in the left-hand side of the spinal canal. And so this is a companion case from a myelogram showing the same thing, a pseudomeningocele. And if you look kind of hard, you can see the contrast bathing this less dense structure, linear structure. That's the nerve, and if you scrolled through this, there was no nerve coming through it. So then you know that nerve root has been sheared. So that's what you're looking for if you're looking for a pseudomeningocele and preganglionic injury. This nerve root has gotten torn off the cord. And there's a coronal depiction kind of showing the same thing. You can see these nerve roots coming out and going through the neuroforamina, and then there's nothing going through that one. So this was similar, but this was an adult, kind of a similar injury where the neck had traction on it. So you can see complete avulsions. They were actually at multiple levels. The nerve roots get torn off and retracted, leaving behind those fluid-filled sacs that you saw. And for this patient, again, no cord signal abnormality. So the preganglionic avulsions, again, are not amenable to surgical repair, so that'll help your referring physicians out, kind of helping them to know, is this a surgical case or not? The postganglionic avulsions can typically be repaired in best case scenarios. And this patient just went to physical therapy, unfortunately. So case number 3, we've got a coronal T1, a T2 weighted. You can see the CSF is bright, so T2 fat suppressed, and then a T1 fat suppressed post-contrast image. And you can see a T1 hypointense, T2 hyperintense, avidly enhancing mass. Same thing here. Arrows just to make sure we all know where it is. So this turned out to be a schwannoma at the path report. Avid enhancement, looks like a schwannoma anywhere else. If you follow the nerve root out, it became fusiform enlargement and then went back to normal size. Problem is these can be indistinguishable from people with neurofibromatosis, neurofibromas, but it is the most common primary tumor of the brachial plexus. And then again, you just want to tell your clinicians where it is. These lesions can get malignant degeneration. If they start to have pain, that's a worrisome sign. And typically, if you take it out, they're cured, and they rarely recur. About halfway through the cases now. These movies go a lot faster, but you can kind of see them coming into this one here. You know there's something abnormal there. These still images are better. So you've got all these rope-like enhancing masses coming out, all the neuroforamina. This is neurofibromatosis. You know, this is what this case is. This patient had plexiform neurofibromas. This is diagnostic of that condition. It's hallmark of NF1. They can get large. They can have malignant degeneration. When you're following these patients, just look for any growth or change in enhancement, because that could mean malignant degeneration. This is a young patient who had a soft tissue sarcoma. So they got a brachial plexus image because he was having symptoms down his arm, and you can see in the axilla there's a lot of T2 hyperintense, but also kind of heterogeneous masses in the axilla and tracking up the brachial plexus. So all these masses in the axilla, this is getting into infraclavicular territory with the terminal branches. And due to compression and also involvement, this nerve root was also involved, tracking all the way back to the neck. So again, those large soft tissue masses and then the signal in the brachial plexus itself. This turned out to be a metastasis from his original sarcoma. Typically, mets in the brachial plexus are going to come from the more common cancers like breast and lung, but lymphoma can also affect these structures. In this case, the sarcoma directly spread and invaded the brachial plexus. And whenever you have diffuse involvement of the brachial plexus, it can be difficult to distinguish that from radiation changes after the patient's been treated. Classic case, lung cancer, new upper extremity pain, motor and sensory plexopathy. You're going to look for the Pancoast tumor. Classic history, a good reason to get a brachial plexus scan. So you've got this mass in the apex of the right lung in the groove there, Pancoast tumor. You have all this T2 hyperintense signal in the brachial plexus. So there, you can see how on these images it's T1 hypointense, enhancing, and you have involvement of the nerves. It's just creeping up into the brachial plexus around, kind of in that retroclavicular region. This is a CT example, kind of better shows the destructive properties of the mass and how it just is encasing the vasculature and these nerve bundles. So superior sulcus tumor, most commonly is going to be squamous cell carcinoma, but you can get adeno. The location of this tumor is what causes the problems. It is right there by the brachial plexus, invades through the apex and gets into those structures. And it can also invade into the spinal canal. So always track your nerves back to the spinal canal to see if that nerve root is involved. It has free reign to go up and down that nerve bundle. So just track it back to look for a spinal canal invasion. Again, obliteration of that interscalene fat. Fat is your friend. If it's obliterated, this can help determine if the patient's a candidate or not. So definitely comment on that. I had never seen this before when I was at Emory. There was a patient who had such bad pain from their Pancoast tumor that they actually ablated the cord. They found the neurosurgeons and the radiologists got together, determined where in the cord that this patient's tracts were running through. They put an RF probe in there, I believe it was, and then they just fried that part of the cord, and the patient's symptoms went away. And he had no luckily, he had no other significant deficits other than what they wanted to happen. But I mean, it's a scary procedure for the patient because, you know, if they burn too much or leave the probe on for too long, it could get more of the cord than they want to and cause all kinds of problems. But this patient did really well. And I think this is the last case. Scroll through this one a little bit slower. So you see all the edema in the musculature. So that's one of those secondary signs. And if you look on the left-hand side of this image, you can see how asymmetric that edema is in the kind of shoulder musculature. So look for that T2 hyperintense signal both in the plexus and the musculature. The bulk was normal in this patient, and there was enhancement. This turned out to be Parsonage-Turner syndrome. Patient had really bad pain in the shoulder. Can be bilateral in up to a third of cases. Your history might be abduction and external rotation weakness. This diagnosis is not specific. I mean, there are lots of things that can look like that, but based on the clinical history and kind of how the patient did after receiving treatment, they ended up thinking it was Parsonage-Turner. But for all intents and purposes, trauma, radiation changes, and quadrilateral space syndrome could all look similar. So this would be more of a differential diagnosis case, but based on the follow-up, it turned out that this one was Parsonage-Turner. So that was a whirlwind tour. I know that's a lot of information, but if you go back to, I try to spend more time on the anatomy and the normal stuff, because if you know what normal looks like, you're going to be able to interpret these cases a lot better. So your nerve bundles on T1 are going to be iso-intense to the scalene musculature, which you're following as a landmark. Compare that, and then compare the two sides. And then just follow the nerve as far as you can and all the way back to the cord. And once you have seen some normal cases, I'm happy to show the abnormal cases to you again if you want to go over it again. And that way, whenever you do get one of these in practice or maybe on call, you'll feel a lot better about it. So I'd like to thank my staff at Emory, because this is where 90% of these cases come from. I'd like to thank the department for having me. I would love to continue to come give you all lectures if you like them. I mean, I love to do it. And then the Overton Brooks VA for letting me come during my work day. So if any of y'all rotate again, come by, say hello. You know, if you want to do some neuro cases, I'm happy to go over some of them with you. And you know, any questions?
Wonderful presentation. It was very easy to understand, simple, very full.
Yeah.
Very didactic.
Yeah, it takes a long time to get to know these cases, but with practice, it gets easier every time. So.
What magnets were you using?
We mostly put our patients on the 3 Tesla Siemens, but there were cases that some of our 1.5 eras were dialed in really well, and we got good images off of those too. I really like, if you have a magnet that can do the really thin slice T2s that you can reformat, I think those are invaluable. You can't always trust the signal in the nerves quite as well, but you can see the nerves, and then rely on your more standard T2 sequences to look for the edema or the abnormal signal. But over at the VA, our magnet is not good enough to do this, but they're supposed to get a 3T and another 1.5, but with the government, who knows how many years it'll be. But we're hoping to get some better magnets in the future. Any other questions? Comments? Concerns?
Great.
All right. Thanks, guys.